Well, thank you very much for that kind introduction. I'm going to take the privilege of the podium for just a second and deviate. I'd first just want to congratulate Dr. Ozicki again for receiving the Distinguished Service Award from the Southeastern Surgical Congress. Grace, I want to thank you on behalf of the Department of Surgery for the contributions that you've made to Emory and Grady over the years that you were in Atlanta, and again, to congratulate you on this tremendous award. I'd also like to acknowledge Wendy Green. Dr. Wendy Green is a member of our department and is the chair of the program committee for this meeting, and congratulations on a great meeting. And then last but not least, to all the Emory folks in the crowd, I really appreciate the support, but also want to thank you for representing our department at this meeting. It really means a lot to what we're trying to do at Emory, and I think it's really fantastic to have you all here. Let me just back this up. I have no financial disclosures, except I just learned this morning that Dr. Joe Sharma, a member of our department, won $6,000 last night at the gambling tables. And so I just want to state publicly that I am expecting my 10% chair's tax, or he's in big trouble. I don't even think he's here. He's probably, oh, there's Sharma, yeah. Well, you know, Dr. Britt ran through a little bit of the biography of Dr. Laws, and you can see I've listed some of this here. I think it's really clear based on his history that he was tremendously committed to surgical education. He was a program director of the general surgery residency at Caraway Methodist Medical Center in Birmingham after his time on the faculty at UAB. As a minimally invasive surgeon, when I looked up Dr. Laws in PubMed, I was so interested to see. He's a true pioneer in laparoscopic surgery. He published a randomized prospective trial in the Annals of Surgery in the 1990s, comparing laparoscopic Nissen fundoplication to laparoscopic Toupet fundoplication, and demonstrated that they were equivalent at reducing symptoms of GERD. He also had some of the first reports of laparoscopic inguinal hernia repair. He's a past president of the Association of Program Directors in Surgery, and also you can see a member of the Board of Governors for the college, and then president of this organization, as well as a recipient of the Distinguished Service Award. So I'm incredibly honored to give this talk, and I want to thank the Southeastern Surgical Congress for inviting me to do so. And I hope that I can add to his tremendous legacy. So the goals I have four simple goals I want to talk to you about. The first is really defining quality and collaboration and how the two interact to improve the care we provide to our patients. I think the next important thing is really discuss the importance of identifying and engaging key stakeholders as you embark on a journey of improving quality. I'll give you a couple examples. One, an example of quality improvement and collaboration at the local level, which is what we call WIG, which is a wound infection group that was put in place at Emory University Hospital to decrease colorectal surgical site infection. And then I'll deviate and to finish up, talk about quality collaboration at the system, state, and regional level, which is also a tremendous opportunity. So I hope to do all that in the next 30 minutes or so, and then leave a little time for questions. Well, wait a minute, how did this slide get in here? So many of you may not know, but you know, in college I played football for the University of Notre Dame. And I think that there's no better opportunity to plant the Notre Dame flag deep in SEC country than this particular talk. So that's the only reason this is actually no. Many folks ask me, do I miss playing football? And the answer to that is actually not really. It was really quite difficult, physically demanding. But what I missed most of it, which has really been hard to reproduce throughout the rest of my professional career, was the teamwork, was the camaraderie, was being a part of a winning team that had one specific focus goal. And I think that that's what this picture shows. It's really a snapshot in time of teamwork in motion. We'll come back to this at the end of the talk, but and it will make sense, I promise. So the strategy for healthcare delivery traditionally has been one of operational effectiveness over the years. And that really is, the more you do, the more you make. And that's how health systems have been focused, and we as individual providers have been focused. You work hard, you grow volumes, and you target well-reimbursing product lines. And the problem with that strategy is over the years, there really was little focus on the quality of care delivered to our patients. And it's only until recently, I would say over the past 20 years, that there's been clear recognition that the way that we provide care and the focus of how we do that needs to be on the value of care provided to patients as opposed to volume or financial reimbursements. And to do that, standardized quality reporting systems are critical, things like NISQIP, STS, VQI, but it also requires collaboration amongst the key stakeholders to make this happen. So let's talk about some of the definitions of quality. If you look in Webster's, this is what you'll see. It says a distinguishing characteristic. My son Keenan has red hair, for example, or superiority in kind, that's a fine cigar. So if you look in the business books, it's really around removing waste or non-value added work. And then I found this, and I won't read this to you because to me, when you talk about quality in healthcare, this really makes little sense, or it's very difficult for me to wrap my head around this. Now, when you talk about being a leader, for me as a leader, I need to be able to understand what the message so that I can deliver it to the folks that I work with, to the team I'm trying to build. And when I have a definition like this, which doesn't make sense to me, it's hard for me to engage. So let me show you one I like. Delivering highly reliable, cost-effective, and safe care that is based on best available evidence, is consistent with patient and family preferences, and delivered when, where, and how the patient wants it. That's easy to get my head around. I can get my head around that. You know where that comes from? Bill Bornstein, who's our Chief Quality Officer at Emory Healthcare. And so this resonates with me. But the other thing I would leave with you is that keep in mind, surgery is a contact sport. And back in the days when I was playing football, the coaches would always say, it's a contact sport. No matter how hard you try, someone's going to get hurt. No matter how hard you prepare, someone's going to get hurt. And I think that's true with surgery in that we do things to patients that put them at risk for complications. And eliminating those complications and improving the quality of care is critical for our patients. So let's jump to collaboration. Again, this is from Webster's, the process of two or more people or organizations working together to achieve a common goal. I can get my head around that. Here's the other one that this is number one that I showed you. Number two, traitorous cooperation with an enemy. And some of you could say, well, you're cooperating with nursing and anesthesiology. What are you? You're a traitor. But I thought that was interesting. But when I looked at the synonyms, if you look at the last one, teamwork, that's what resonates with me. Teamwork. We work together as a team. We build teams to provide the best care possible. The benefits of collaboration can be far-reaching. I think some of the strongest organizations in the country, whether in healthcare or in business, have tremendous teamwork. But it's the ultimate herding cats, and sometimes it's not just herding cats; it's herding Bengal tigers. It's really difficult and takes skilled leadership to make it work. And it takes a leader that really can identify, understand, and engage the key stakeholders so that you can meet your goal. So who are the stakeholders when it comes to advancing surgical quality? I'll list them here for you. These are off the top of my head. This is number one. It's got to be our patients and their families. That's our true north, and that should be our focus on what we provide. I have this saying, there's too much surgeon-centric thinking in American healthcare today, or physician-centric thinking. We have to put the patients and the families in the center. Payers also, unfortunately, are a stakeholder in that they control the purse strings to a degree, and so they're a critical stakeholder. So each of our health systems, they're important. And then finally, the providers, and that's referring physicians, surgeons, those of us in the room, but our anesthesiology colleagues and nurses, all of us are key and critical to advancing quality for our patients. So let's talk about what does each stakeholder want. Well, as I mentioned before in that definition of quality, patients and the families simply want the highest quality care available at the most cost-effective price. And they want it when where it's convenient. They don't want to have to struggle to park. They don't want to have to wait forever to get in to see the doctor. Payers want high quality and low cost, and they recognize more and more that low quality increases costs, and so they're starting to buy into this idea of quality improvement. The health system is looking for, again, high quality care at a market competitive price, and that's really critical. It needs to be competitive with those health systems within the region. One of the things that we've all seen is that they're concerned about the cost of care, such that they're concerned about even the nominal amount of money that it takes to participate in some of these quality programs. So it's incumbent upon us to really keep hammering home the value of participation in these programs. And finally, providers, well, we just want what's best for the patient. We want the resources that are necessary to provide the best care to our patients, and quite frankly, we're all inherently competitive and want to get better, and so with the appropriate information, we will move towards the best care possible. So let's talk about an example of quality collaboration in a local QI process. And so the Wound Infection Group Colorectal Surgical Site Infection Initiative at Emory University Hospital. You can see this is Joe Sharma. Joe's our Vice Chair for Quality, Safety, Care, Innovation, and Gambling, I guess. And this is Grant Lindy, who's Joe's counterpart in the Department of Anesthesiology. And what happened was in 2011, we got our semi-annual report from NSQIP, and we had a Houston, we have a problem moment, in that we were a high outlier for colorectal surgical site infections. Our OE ratio was 1.6, essentially, which means that we're having 60% more surgical site infections than would be expected for our patient population. And I remember the conversation I had with Joe. I said, are we consenting our colon surgery patients, telling them that you have a 60% higher chance of getting a surgical site infection by having your surgery here at Emory? And we knew we needed to really address this. And so being the great leader that I am, I just said, Joe, fix it. And he did. But this is how he did it. So he was really thoughtful and deliberate about developing what we call the Wound Infection Group, or affectionately WIG. And you can see he was so thoughtful. He incorporated, so many individuals. When we would have our WIG meetings, there would be 15, 20 people around the table. I'm going to pause and let you look at this for a second. What stakeholders missing? It's a really key one, and it was just not obvious to us. We missed it totally. There's no patient on here. But we picked that up. We caught that. But so many people say you can't have a big meeting with 20 people around the table. It's not going to be successful. With Joe's leadership skills, were effective in pulling people together and sharing ideas, and it's necessary to have those stakeholders involved so that you can create an intervention that everyone agrees on, and it's not going to hit a road bump. So the goals that came out of this were, we wanted to improve our surgical site infection rate down to an OA ratio of 1. And so the group built what we call the WIP, the Wound Infection Prevention Process. And they scoured literature, they talked to multiple stakeholders, and came up with this prevention process, in the pre-op, peri-op, intra-op, and post-op portions of the patient's journey that really made significant differences. Some of this was based on best evidence available. Some of it was based on just conversations with individuals. But these ultimately are things that we all agreed upon and then put in place to impact the wound infection problem. And so back to the patients, one of the things we did is, in working with our patients, when we said we were going to have everybody do a chlorhexidine shower, they didn't have any idea how to do it. They just put it in their hair and be done. And so we created, with the help of one of our biovisualists in the Department of Surgery and patient input, a simple instruction sheet of how you do a chlorhexidine shower the night before surgery. We developed an iPad app. We call it the Come Clean app, that when our patients are waiting in the anesthesia pre-op clinic to do their pre-op visit, that they can go through that has information of why they should stop smoking before surgery, and it's presented in a way that the patients can grasp, as opposed to with a bunch of data that's important to us. When talking about smoking cessation, the importance of glucose control for diabetics around the time of surgery, and then things like the myth of MRSA and/or when do you need to be worried about MRSA. And the bottom line is that this is when Joe put the wig in place. Here's when we implemented our colorectal whip, and you can see that we dropped, with this quote-unquote secret sauce, we dropped the observed number of surgical site infections below that. It was that of expected. So it was a tremendous victory. I hurt my shoulder patting myself on the back. I was so excited. And again, here is our overall SSI rate, which again, if you look around the same time frame, that too, there's a Hawthorne effect to a degree, but we also dropped for the entire institution below an OE ratio of 1. So we were excited, but then we got a little too full of ourselves and we rebounded. And we lost some of our momentum. And so because of this, the hospital acquired condition quality acceleration team was formed by the system. And the reason that this occurred is that not only did they notice an uptick in surgical site infections at the university hospital, but other hospitals within the system had increased rates. And because of this, resources were brought to bear that allowed us to really do a deep dive. And what we found was that the majority of the surgical site infections were associated with an antibiotic miss. And it wasn't that the patients weren't getting the appropriate antibiotic. It wasn't that they weren't getting an antibiotic. They weren't getting the appropriate antibiotic, or a redose was being missed. And so with the help of our pharmacists, infection control folks, the infectious disease department, we looked at the profiles of the antibiotic profiles of bacteria in our system, and we developed a standard antibiotic order set, again referencing best practices in the literature, but specifically targeting it based on our patient population. And we developed a standard antibiotic order set. The next thing, which was really hard, which shouldn't be hard, but it was really hard, was changing the perioperative antibiotic ordering from an opt-in to an opt-out decision, right? Opt-in means that you have to actually, there's transaction costs, you have to actually do something. And what we were seeing is that, there was delays around the time of surgery, that the surgeons had to enter the order before that the antibiotic could be pulled from pharmacy. And because of all this, there are times when the antibiotic didn't go in before the skin incision was made. We've changed that to an opt-out, so the anesthesiology team knows exactly what the standard antibiotic order set is, and they know the reasons that you would deviate from that. And so they hang the antibiotic no matter, without an order, and it's hung before skin incision is made. And that's had a dramatic impact across the system. The last thing that occurred is we created an automated next day report for all failures. And so here's a copy of one that I received. We did a complex abdominal wall reconstruction, and those usually take, it's a 2-team procedure, and those usually take more than 4 to 5 hours to do, and we missed the redose. Now, thankfully, this individual didn't develop a wound infection, but this stuck with me. And now when we do our preoperative briefing, through the surgical checklist, if I know this is going to be a long case, I am telling the anesthesiology, pay attention, don't miss the redose. We're going to be here long enough that this patient's going to be eligible for a redose. So this is a great example of how working together with multiple members of the team, of how collaborating, that we were able to really make a dramatic impact on surgical site infections. And so you can see with this work, we're back down below an OE ratio of 1, and again, quite excited. But the real deal here is look, when you look from when we started to when, in 2017 when we calculated this, we eliminated surgical site infections in 443 patients, most likely. And the cost of that's dramatic, but also, just think about the patients avoiding that complication. That's dramatic. It's a dramatic impact. So I think that collaboration at the entity level is key. You have to, do all the things I talked about. You have to define your intervention. It needs to be something that all stakeholders can wrap their head around and agree upon. When you're defining your key stakeholders, don't be disappointed if despite your best intentions, someone is omitted. Apologize, ask them to participate, and move forward. Keep assessing, keep refining. We're building diamonds here. We're making diamonds. That takes time and pressure. It doesn't happen overnight. The work is never done. Let's shift gears and talk about quality collaboration at the system, state, or regional level. This is a paper that was published in Annals of Surgery in 2009. It's from a group in Ontario, Canada, interestingly. But actually, if you understand how healthcare is provided in Canada, there are portions of, for example, I just visited the University of British Columbia. It is the only academic medical center in the entire province of British Columbia, and they are charged with education, quality of care, et cetera, across that entire geographic area. And so things like a regional quality collaborative make sense for them. That's how they have to survive. And so this paper is really interesting because it lists some of the tools for quality improvement in surgery around regional collaborations. And so, one of the benefits of a quality collaborative is obviously the exchange of ideas and the ability to solve problems, using the experiences of others within the collaborative. And generally, you'll have similar patient populations. So patients in Georgia are much, across the state of Georgia are much more similar than, say, patients in Atlanta and Seattle. It allows you to share data and create specialized reports, which will identify outliers or best practices. But more importantly, it catalyzes relationships across institutions that are in general competitors. And it's these relationships that allow you to work together to move the bar. And in the end, it increases the value of the care we provide to our patients. I think these are also potential platforms for collaborative clinical trials, for example. And this last reason that I found is actually something that I found in reading an article in JAMA last week, but it's also a potential platform for health system crisis preparedness. And so this is, came out online in JAMA on just last week. It's by Don Berwick, and talking about preparedness for health system health threats across the United States. And I think it was specifically written in mind with what's going on in China with the coronavirus. And he listed five things that could be done to enhance our preparedness. And number 2 of those 5 was develop a system of regional collaborative projects. And what he's citing here was, with the Ebola crisis that occurred, and Emory was along with the University of Nebraska and Bellevue Hospital, they were engaged in developing a response to that. But I think it really provides the opportunity for us to be prepared and to work together to be prepared and ready to deal with some type of health system health threat to our region. So what are the core principles for a collaborative? Well, you want to maximize exchange of the best ideas through collegial and family-friendly interactions. You need a standardized reporting system. I think most successful collaboratives would tell you that it really revolves around having the right leader in place, the right clinical leader that catalyzes or pulls together the other stakeholders. You do need administrative leadership because there is a tremendous amount of administrative work that's necessary to make this go, both in terms of infrastructure and methodologic support. And if possible, it's critical to identify a stakeholder that might cover the administrative costs for such a program, which is really one of the barriers for these to be established. And so, it's important to have regular meetings where you're actually face-to-face with the individual members of the collaborative. You want to develop a project initially that is, if you will, something you can deliver upon. And that has to have the agreement of all participants. And so it's really important that you choose wisely. And this is a blast from the past from Indiana Jones, the Last Crusade, Indiana Jones on the Last Crusade. This is the knight that's in the Grail room, if you remember. And this is where he's telling Indy, after he picks up the Grail and drinks from it and doesn't die, you've chosen wisely, right? So it's really critical that we choose wisely with the projects that we're going to do, because if you fail on the first one, you don't get a second chance in general. So you want to pick one that you can succeed with, pick one that has agreement. What are the challenges? Well, funding is critical for this. And who are the people that you could approach potentially that might agree to fund this and folks have had success with? Payers, potentially foundations or philanthropic sources. One of the ones that we've tried is the malpractice insurance companies, in that if you're driving down quality, you likely will be driving down malpractice claims, and therefore it's in their benefit to invest. Haven't been successful with that yet, but I think keep trying. You can approach government, and I'll give you an example of where that's occurred and made a difference, and then the State Hospital Association. You also have to remember that this is collaboration and not competition, and many of the people that are going to participate in the regional collaborative are actually financial competitors within the region, and so it has to be about collaboration, not competition. And it needs to be known that that's a deal breaker. If someone starts competing with information from the collaborative, they're out. Again, choose a project that resonates and is doable, and follow through. Success breeds success. So this is a picture of Skip Campbell. I'm sure a lot of you in the room know Skip, and for those of you that don't, Skip was the section head or the chief of general surgery at the University of Michigan when I joined faculty there in 1995. He about 3 years after I joined the faculty, he made a decision that he did not want to be a surgery chair, and so he stepped down as section head. And actually what he wanted to do was focus on quality. Around that time, he had met Shukri Khoury, who is one of the founders of the NSQIP and the VA system. And after conversations with Shukri, Skip had the thought, well, could this system that the VA is using to focus on quality, could it be applied in the private sector? And so with friends at the University of Kentucky and at Emory, he did the first private sector pilot of NSQIP. And then the college helped sponsor a larger study with 16 institutions that had federal funding, which also demonstrated that this program could be applied in the private sector, and the rest is history, really. I mean, now NSQIP in the United States has over 700, almost 800 participants, but it really comes out of Skip Campbell deciding he wanted to pivot and focus on quality and patient safety. Well, after he did that, one of the other things that he had an idea about was that he thought it would be really interesting to develop a collaborative in the state of Michigan around quality. And so this is the initial slide from I think that's the late 1990s or early 2000s I think it's it's the original 30 plus hospitals in the state of Michigan that participated in the MSQC, the Michigan Surgical Quality Collaborative. Skip was able, through a relationship with someone at Blue Cross Blue Shield of Michigan, to obtain funding to cover all of the costs for participation in NSQIP. And he called it, instead of pay for performance, he said it was pay for participation. If you participated in MSQC, the costs of participating would be covered by Blue Cross Blue Shield. He established this collaborative group, and with the help of Blue Cross Blue Shield, Michigan was able to move things forward. They had a standardized outcomes program, began to capture data and identify variation in outcomes within the group, within the state of Michigan. They identified best performers, they visited best performers, and identified best practices that could be disseminated across the state. They had quarterly meetings. After I first got to Atlanta and at Emory, he invited me up, and I went to one of the quarterly meetings. The guest speaker at the quarterly meeting was Hiram Polk, talking about some of his insights in wound infection and eliminating wound infection. And that was, I think, probably 2007. You can see some of the regional initiatives they put in place and had significant improvement in morbidity and mortality. This is an article that was published in the Annals of Surgery in 2007, which demonstrated that these investments paid for themselves. And so, they are now more than 70 hospitals in the state of Michigan participate, or over 2,500 surgeons. It's really remarkable. There's been spinoffs. There's a Michigan Bariatric Quality Collaborative, a Trauma Collaborative, and CT Surgery and Vascular Surgery Collaborative. So it's really remarkable the differences that they're making in the state of Michigan with this concept. Well, about the time Skip really started talking about this in 2006, 2007, Joe Kofer heard him talk at a meeting. And he thought, this is great. I actually reached out to Joe, told him I wanted to talk about quality collaboratives, and spent probably 30 minutes on the phone with him just a couple days ago. And he kind of walked me through how he brought those concepts and was able to create the collaborative in Tennessee through friendships and relationships with people all across the state of Tennessee, but also with a relationship that he had with an individual at Blue Cross Blue Shield of Tennessee. The initial program was built as a tripartite leadership program with the surgical leadership, if you will, Blue Cross Blue Shield of Tennessee and the Tennessee Hospital Association. Blue Cross Blue Shield of Tennessee said, we will fund this. It's going to be seed funding, but it's time limited. It's up to you to identify sustainable funding to make this last long term. But they were incredibly successful, and now it is funded by the Tennessee Hospital Association, although the funding for participation in NSQIP is now on the system or the hospital to provide. Joe sent me some slides and said I could show you these. But this is a study that was presented at the National NSQIP meeting by members of the collaborative, looking at the impact of outcomes for patients and financial savings that this collaborative had. Now, this is a bit of a busy slide, but really what I want you to look at is the decrease in the number of complications and the percentage of complications per 1,000 patients from 2009 to 2015. It's dramatic. And when you actually calculate the cost savings by decreasing these complications per 1,000 cases, almost a $3 million decrease in the cost of complications. And then when you normalize that over the years and for the number of patients that have been taken care of, I think the number is $64 million. It's dramatic. And so these are the kinds of things that number one, that are derived from participation in a collaborative, but this is information that you have to create that allows you to circle back with your important stakeholders and show that you've delivered for them so that they will continue to invest in your initiative. Here's another one from if you will, Southeastern Surgical Congress territory. I was at the Michigan Collaborative meeting. They had an annual meeting where they had a breakout session on developing collaboratives that I went to. And the South Carolina group reported it was newly formed in 2014, but they've got funding from Blue Cross Blue Shield of South Carolina, and you can see all the institutions in South Carolina that are participating. So again, a great example that was able to make do by obtaining funding through the insurance provider. What I want to talk to you about, just to finish up with, is really a fledgling collaborative we have ongoing in the state of Georgia. This is unique in that the funding that we've identified, and I shouldn't say we, the funding that's been identified it comes from the government. And we've been talking about a collaborative in Georgia since 2009, and there's multiple individuals that are interested, but we just never could come up with the resources for the administrative support. And I know I've seen Dennis Ashley. Dennis is here somewhere, but Dennis, is a member of this organization, chair of surgery at Mercer in Macon, but is also the chair of the Georgia Trauma Commission. And Dennis had the idea And he delivered on this idea by talking to the state legislature that earmarking a portion of the budget that goes to the Georgia Trauma Commission to fund a Georgia Quality Improvement Program that focuses on not just trauma, but also focuses on surgery and also on the pediatric surgery realm. And so this is really a novel way to approach this, and it's been a game changer for the collaborative in Georgia because we now have the infrastructure to do the work. And so things that we're looking at, we've identified signals in postoperative renal failure for patients, general surgery patients, trauma patients, pediatric surgery patients. And through all those lessons, we're coming up with things like protocols around when is IV contrast necessary for a CT scan, and so on. But we're still very early in the process, but again, a novel way to approach this. So I think collaboratives work. The benefits are tangible. You can see them listed here. Challenges are many, but perseverance is the key. All right, so let's finish up. As I said, this is a snapshot in time of collaboration or teamwork in motion. So when you look at this, first thing is the colors are so vivid, which really strikes me. This picture was taken in 1980 by a student at Notre Dame who's just had a hobby for photography. He was not a student on the student newspaper. It's really amazing. I bought this from him when I went to his dorm room, and man, am I glad I did. Look at how synchronized we are. I mean, it's like we practiced, we posed for this. But this is right after the ball had been snapped, and we're all moving. We're all moving at the same time, yet we're all looking at something different, right? Each of us has a different job, but we're moving in concert. And what I would tell you is that each of us knows what the other guy's job is as well. And we will react if there's changes in the way things are presented to us in the situation to provide the best outcome. I think it's really cool if you look in the background, you see the fans. It's a really sunny day. Actually, this was our last home game of the 1980 season, and it's in late November. And Notre Dame Stadium didn't have lights at that time, so we had to start every game at noon. And so this is really actually, probably 3 o'clock in the afternoon, and the sun's going to be going down shortly. But the fans are watching, and they don't know the ins and outs of the plays. They don't know if the play fails. Was it a bad scheme? Do you not have enough talent? Did they have a better idea? But they know when it fails. They can tell, and that's our patients. Our patients don't necessarily understand why the outcomes that are negative for them occur, but they notice that they are negative. And then I think this is cool. I couldn't stand this referee. He did so many of our games, and God, he always called. My best friend here is Phil Pozderac, our offensive tackle. He always called Phil for offensive holding. I just couldn't stand this guy. He wore a little turtleneck, and I just wanted to wring his neck every time he threw the flag. I called him, anyways, I won't go any further, but what's interesting about this is, first of all, just look at how this is framed. I mean, my gosh, what a great picture. But, the way I look at this is that, we have to be mindful that people are watching, that not only is it incumbent upon us to provide the best outcomes for our patients, but people are watching. And so I can think of no better reason if you can't get behind doing what's best for the patient, than just to keep that in mind. So in closing, I just want to thank the Southeastern Surgical Congress for this tremendous honor. I really appreciate it, and be happy to take any questions if there's time for that. You can go to a website where the Notre Dame, when you're going down the steps in the stadium down to go onto the field, at the bottom of the steps there's a sign that says "Play Like a Champion Today," and they have a website where you can go and create whatever you want. And so Emory guys, you're going to have to punch this before you go into the operating room. Feel like a champion today. Okay. Anyway, thanks again. I really appreciate the opportunity.